Dr. Mamun, you can start.
Ladies and gentlemen, it is my pleasure to welcome you today to this webinar on chronic liver transplantation and chronic liver disease. This is being organized by Forum for the Study of the Liver Bangladesh and Bangabandhu Sheikh Mujib Medical University Hepatology Alumni Association, joined with Narayana Health India. We all know of Narayana Health. It's the flagship hospital chain in India, established by the legendary cardiac surgeon Dr. Devi Shetty. We have with us Beacon Pharmaceuticals as our scientific partner, and the media partner is Raj TV. So this webinar will not only be limited to the participants only, but a few more thousand physicians and other people will be able to see it online, which will be live at simultaneously. So from Narayana Health, we have two eminent speakers with us today. We have Dr. Sanjay K. Goja, who is the Director and Clinical Lead of Liver Transplant, Hepatopancreatic Biliary and Robotic Surgery at Narayana Health in Bangalore. He is a eminent liver transplant surgeon and also a very well-trained robotic surgeon, got his training in robotic surgery from Japan. He will be highlighting on liver transplantation, but the lectures will begin with Dr. Shandip Pal. Shubha Sandhya Shandip. Shandip is a Bengali, but for the sake of an international ambience, we'll speak in English. Shandip is a consultant interventional gastroenterologist and hepatologist at Narayana Health, Rabindranath Tagore International Institute of Cardiac Sciences in Kolkata. Before that, he was working as an assistant professor in the Department of Gastroenterology, a very young, promising hepatologist. He will be speaking on the management of chronic liver diseases. Before we go on to the lectures, let me introduce you to the eminent panel of experts that is with us today. We have from Kumilla Medical College, Dr. Daliluddin. He's an assistant professor of hepatology there. We have Dr. Debraj Malakar. He's a hepatologist working in Munshiganj. We have Dr. Mohammad Saidul Haq, assistant professor of hepatology at Shohid Tajuddin Ahmed Medical College in Gazipur. We have Dr. Mohammad Asaduzzaman, assistant professor and head Department of Hepatology at Mugda Medical College, Dhaka. Next is Dr. Abidur Rahman Kimi. He's a resident physician, basically hepatologist at Shohid Nazrul Islam Medical College in Kishoreganj. We have with us Dr. Abul Hayat Manik, hepatologist at Dhaka Medical College Hospital in Dhaka. And finally, we have Mr. Guru Prasad, who's the marketing, the international group lead in international marketing, international division of Narayana Health. So without wasting any further time, it's my pleasure to inviting Dr. Shandip Pal from Kolkata, from NH Rabindranath Tagore International Institute of Cardiac Sciences, Kolkata, to highlight, to enlighten us on the management of chronic liver disease. Dr. Shandip Pal, please.
Yeah, am I audible, sir?
Yes, you are audible, Shandip.
Yeah. Good evening, sir. Dr. Mamun and all the panelists who are on board today, Dr. Goja, good evening. So I will share my screen. So are my slides visible?
Yes, we can,
yes.
We can see your slide, yeah.
Yeah, so the topic given to me is management of chronic liver disease. And how much time do I have, sir? How much time? For 20 minutes?
Yeah, around 20 minutes, Sandeep. 20 minutes for each lecture.
Okay, sir. So the topic given to me is management of chronic liver disease. So discussing about chronic liver disease. So what I will do, what I have planned today is, so chronic liver disease, as we know, the causes of chronic liver disease I have highlighted here, the common causes of chronic liver disease. So I will be discussing the management of the complications and the various features which develops in chronic liver disease rather than discussing the etiology of chronic liver disease. So the management of the etiologies of chronic liver disease, we all are very aware. So if the patient is alcohol related, we treat, stop alcoholism. If the hepatitis B or C, we have to treat accordingly the treatment of hepatitis and B and C. This is the easy part, which I will say in the management of chronic liver disease. Or other etiology can be autoimmune hepatitis, non-alcoholic steatohepatitis, which is the most commonest, which is fast becoming the most common cause of chronic liver disease. Then drugs and toxins, various drugs that is used for the treatment of all medical ailments like methotrexate, one example. Then toxins, the various alternative medicines that are used that might cause chronic liver disease or acute liver failure or jaundice. So then there is another variety of etiologies like cholestatic disorders like primary biliary cirrhosis, primary sclerosing cholangitis, and of course the metabolic causes like Wilson's disease, glycogen storage diseases. So these are the common etiologies of chronic liver disease that we see in our day-to-day life, day-to-day practice. So now these are the clinical features, the signs of chronic liver disease. This is one diagram which all of us have seen. It's there in the textbook of Davidson, and any standard textbook we see all these manifestations of chronic liver disease are there. The various features of portal hypertension and the effects of liver cell failure. So I'm not going into the details of this. Like this is according to the manifestation of the disease. When the disease manifests, these are the various clinical features that we note, starting from the jaundice. If we start from the head, facial puffiness, then coming to the abdomen, all spider nevi. And then to the chest wall, there can be ascites, there can be dilated veins in the abdomen, then pedal edema, palmar edema, Dupuytren's contracture, ascites, all we know about all this. So these are the various signs and symptoms of chronic liver disease. Now to discuss about the management of chronic liver disease, so what I will do in my presentation is I will basically discuss the various manifestations, the complications of chronic liver disease, which is most important thing. And Dr. Goja will be discussing about, we consider it as a multi-stage model for the treatment of cirrhosis of liver. So there are two stages of chronic liver disease. One is compensated cirrhosis, another is decompensated cirrhosis. Now, transition from compensated cirrhosis to decompensated cirrhosis occurs at a rate of about 5 to 7% per year. So compensated cirrhosis means the patient is well compensated and has not developed any sign or symptoms of decompensation like bleed, ascites, or hepatic encephalopathy, and all other complications. Now, decompensated cirrhosis is a systemic disease with multi-organ system dysfunction. Now, there are various stages of liver disease, like stage 0, there is no varices, mild portal hypertensive gastropathy, where the liver stiffness measurement is more than 15 but less than 20. And if we measure the HbPG, it is more than 5 but less than 10. Then stage 1 is no varices, but clinically significant portal hypertension is there, where the liver stiffness is more than 20 and HbPG is more than 10. And stage 2 is varices are there, where it is clinically significant portal hypertension. And stage 3 is bleeding. There is bleeding from the varices. Stage 4, the first non-bleeding decompensation might be in the form of ascites. And stage 5, the second decompensating event. And lastly comes the end-stage disease, that is the late decompensation, where there can be refractory ascites or persistent portosystemic encephalopathy or jaundice, infections, renal failure, which again can lead to acute on chronic liver failure and ultimately result in death. Now, between this compensated and decompensated stage, it can be interchangeable, not always, but depending on the etiology of the disease, like why the liver becomes cirrhotic. Like if it is an alcoholic, sometimes we see once the patient stops alcohol, and if we are able to manage it well, then the patients might come back from decompensated to compensated state. But mostly, if it becomes once decompensated, it's difficult to reverse it to compensated state. So we say the compensated, if it is the patient is in a compensated state, the patient can be asymptomatic. The median survival is around 12 years. But once the patients become symptomatic, then the median survival is only 2 years. And once the patient becomes symptomatic, we should always evaluate the patient for liver transplantation. Now, the pathophysiology of decompensated cirrhosis. So once cirrhosis develops, there is the development of portal hypertension. And once there is portal hypertension, there is bacterial translocation, which causes activation of innate pattern recognition receptors. There is release of pro-inflammatory cytokines molecules like the reactive oxygen species and nitrogen species, which causes splanchnic arteriolar vasodilatation and cardiovascular dysfunction. So this ultimately leads to adrenal dysfunction, HE, hepatic encephalopathy, kidney dysfunction, ascites, hepatopulmonary syndrome, all others. So the main thing is bacterial translocation and the development of portal hypertension. So, and these are the various complications of chronic liver disease, that decompensated cirrhosis that we face. One is ascites, hepatic hydrothorax, renal impairment, bacterial infections, cardiopulmonary, which encompasses cirrhotic cardiomyopathy, hepatopulmonary syndrome, and portopulmonary hypertension. Then there can be GI bleed, there can be relative adrenal insufficiency, hyponatremia, and hepatic encephalopathy. So what I will do is I will touch upon all these complications a little bit and discuss the management of these conditions. So overall management of decompensated cirrhosis is suppression of the etiological factors, which is the most important. I think it's easy. We all know about the treatment of hepatitis B or hepatitis C or autoimmune hepatitis, then treatment of key pathogenic factors and the management of various complications. So if you look at the overall management of decompensated cirrhosis, management should aim to prevent progression of the disease as well as treat complications. And no treatment exists that can act on cirrhosis progression directly. That means those anti-fibrotic or anti-cirrhotic drugs are not yet there in the market. So we have to treat the complications as well as treat the etiology of the disease. So we have to suppress the etiological factors that cause liver inflammation and cirrhosis development, and also target key factors in the pathogenesis of cirrhosis, decompensation, and progression. So this is a clinical guideline from the European Association of the Study of Liver Disease, where they say in patients with decompensated cirrhosis, the etiological factors should be removed, particularly alcohol consumption, hepatitis B or C, as this strategy is associated with decreased risk of compensation and increased survival. And there is grade of recommendation is 1. So it is an established factor that we have to treat the etiology. And the treatment of key pathogenic factors also, like treating the microbiome abnormalities and the bacterial translocation to improve the gut-liver axis. So we can use drug rifaximin in that. Then improve the disturbed circulatory function like long-term albumin. There are studies also published in various journals like long-term albumin has got a favorable effect on the progression of liver disease. Then treatment of inflammatory states, statins, this is still upcoming, and treatment of portal hypertension by beta blockers. So now coming to each of the complications like ascites. So ascites is the most common complication of decompensation. It occurs in 5 to 10% of patients with compensated cirrhosis. It impairs patient working and social lifestyle. It is the frequent cause of hospitalization, requires chronic treatment, and it has got a poor prognosis. 5-year survival is around 30% once the patient decompensates in the form of ascites. So ascites can be uncomplicated or refractory. So if the ascites is uncomplicated, first of all, cirrhosis is the cause in 80% of the cases. Initial patient evaluation is history, physical examination, abdominal ultrasound, various laboratory assessment, and there is grading of ascites also, like grade 1, grade 2, grade 3. Grade 1 is mild ascites, grade 2 is moderate ascites, and grade 3 is large or gross ascites. These are of in an academic institute, we have to teach our students all this. So practically also this is important, but it's more of academic interest. So now uncomplicated ascites. So once we get a patient of ascites, first of all, we should rule out SBP. We have to do an ascitic fluid culture or ascitic fluid count. If the neutrophil count is more than 250, it signifies SBP. And the ascitic fluid protein estimation is very important, because the ascitic fluid protein, if it is less than 1 gram, that means the patient is prone to develop SBP infection. So this patient should be under antibiotic prophylaxis. And also SAG is always calculated to differentiate between exudative or transudative ascites. And development of ascites in patients with cirrhosis is associated with poor prognosis. As I have mentioned, the 1-year mortality is 40% and 2-year mortality is 50% if the patient is not treated. So since the development of grade 2 or grade 3 ascites in patients with cirrhosis is associated with reduced survival, liver transplantation should be considered as a potential treatment option when the patient has grade 2 or grade 3 or refractory ascites. Now, the initial treatment of uncomplicated ascites is hospitalization may not be required. We have to restrict the sodium intake. That means what we say in our common language to the patients is to decrease. It should be less than 5 grams of common salt every day. And also no added salt should be given in the prepared meals. And very low sodium diets also should be avoided, because hyponatremia, again, we know, is a very challenging condition to manage in this group of patients. And if you need the drugs to start in ascites, the first drug of choice is an anti-mineralocorticoid drug, that is the aldactone, spironolactone. We use spironolactone, the initial dose may be 100 milligram per day, and we can go up to 400 milligram per day. And if it is difficult to control with spironolactone, we can add on loop diuretics to this, and we should monitor the side effects which can develop to these drugs. Now, the recommended maximum weight loss is 0.5 kg per day in patients with edema and 1 kg per day in patients with edema. That means without edema, only ascites, we should target at minimum 0.5 kg per day. And if the patient has edema, the target should be 1 kg per day. And after now coming to grade 3 ascites, so if we are not able to control the patient with these drugs, then if the patient has got grade 3 ascites, then large volume paracentesis may be required. And for large volume paracentesis, if we take out more than 5 liters of ascites, then plasma expander should be given. We usually give albumin during paracentesis. Now coming to refractory ascites. So refractory ascites means if the ascites cannot be mobilized or the early recurrence of which cannot be prevented by medical therapy, there are two varieties. One is diuretic resistant and diuretic intractable. Diuretic resistance means the patient is not responding to diuretics, and diuretic intractable means we are not able to give the diuretics because of the development of complications of diuretics. So if a patient has got refractory ascites, then the treatment varies. So the treatment should be again, patient should be on intensive diuretic therapy. We should attain the maximum dose of diuretic therapy, that is 40 milligram of up to 80 milligram of loop diuretics and 400 milligram of spironolactone. If after that also, if fluid cannot be mobilized, then we label the patient as refractory ascites. So what we can do for that, the treatment for refractory ascites is the patient should be evaluated for the various complications, bleeding or infection. And if the patient has got refractory ascites, the treatment is liver transplantation. And if by chance the liver transplantation, because it's not very easy to do liver transplantation, if we have to wait for liver transplantation, then in the meanwhile, the patient subjected to tips, because that can help in, that can buy time, because doing LBP again and again can develop SBP and various complications, post circulatory disturbance, various complications can develop, or repeated LBP plus albumin or tips. So this can be done in the management of refractory ascites. Now coming to another complication, that is hepatic hydrothorax. So hepatic hydrothorax means accumulation of transudative fluid in the pleural space, which can move through small diaphragmatic defects. It can lead to respiratory failure. And once this hepatic hydrothorax develops, the median survival is only 8 to 12 months. And the diagnosis is, once pleural effusion has been ascertained, cardiopulmonary and primary pleural disease should be excluded. And the treatment for hepatic hydrothorax, again, we can do drainage, but drainage, and now doing hepatic, thoracocentesis again and again can be difficult for the patients. If sometimes hydropneumothorax develops, then the patient has to be on chest tube. So once the patient develops hepatic hydrothorax, the liver transplantation should be advised to the patient. And if it takes time for the liver transplantation to happen, in the meantime, we can offer tips as a bridge therapy for liver transplantation to these patients. And also in literature, they have mentioned about pleurodesis as the treatment for this ascites, but I personally, I don't believe that pleurodesis helps in this condition, because whatever patients, few patients we have seen on pleurodesis for hepatic hydrothorax, they have again a fluid reaccumulation occurs. So pleurodesis, in my, to me, it works best in exudative ascites and not in transudative ascites. And transudative, sorry, pleural effusion. So next common, another complication that we see is hyponatremia. It's common in patients with advanced cirrhosis. Arbitrarily is denote hyponatremia when the serum sodium is less than 130. There can be hypo and hypervolemic hyponatremia. It is associated with increased mortality and morbidity, and particularly neurological complications, and it is reduced survival after this. So it is a negative predictor. So once a patient has got hyponatremia, the outcome of liver transplantation is also not good. So the treatment of hyponatremia is fluid restriction to around 1 liter per day is recommended, and also removal of the cause and administration of normal saline are recommended in the management of hypovolemic hyponatremia. And it is a very dicey situation, because if we give normal saline as the treatment, more fluid reaccumulation occurs. So it is very difficult to manage hyponatremia in patients of decompensated cirrhosis. Now, another common complication that we see in our day-to-day practice is variceal hemorrhage. That is, here you can see a picture of large varices with red color signs. It occurs when the varicose wall ruptures due to excessive wall tension. Portal pressure is a key factor. And 70% of GI bleeding events result from variceal hemorrhage in patients with portal hypertension. And it's the second most common decompensating event after ascites. And it's the most severe and immediate life-threatening complication can occur. So patients with decompensated cirrhosis are at high risk and should have endoscopy to screen for varices. And if endoscopy is performed, the present size and the presence of red oil marks should be reported. And if large varices are present, so now the guidelines are that we do variceal ligation if only the patient bleeds. That means secondary prophylaxis. But now newer studies have come which shows that the addition of beta blockers plus endoscopic variceal ligation is better than only drugs alone. So if the varices are large, primary prophylaxis should be given, but in addition, we can also do banding at the same time. So ascites is not a, now again, there is a thought that there are few studies that if the patient has got ascites, then we should not give beta blockers, but ascites is not a contraindication for beta blockers. Caution should be exercised in case of severe or refractory ascites, because if we give non-selective beta blockers, there is hypotension. When there is hypotension, the effective circulatory volume to the kidney decreases, and so there can be a chance of kidney dysfunction. So we should be cautious, but it can be given. So combination therapy of non-selective beta blockers and endoscopic variceal band ligation is recommended. And if the patient has got a severe bleed, this is the algorithm for the management of GI bleed. So if the patient has got GI bleed due to portal hypertension, initial assessment and resuscitation should be done. We all know about this. Then till the time we do endoscopy, we can start on vasoactive drug therapy like terlipressin or octreotide or somatostatin. We should start an antibiotic prophylaxis, then try to do the endoscopy as fast as possible, confirm variceal bleeding, and do an endoscopic band ligation. Now, if the patient has got child B or child C, and it's difficult to control the bleed with the band ligation, because if the portal hypertension, if the HBPG is very high, then we should consider early tips in high-risk patients, because there are studies which have shown if we consider early tips in these patients, then the outcome is better than waiting for the patient, waiting for the tips to do later. So now coming to the next complication, that is bacterial infection. This is again one common complication that we see in patients with cirrhosis of liver. So the risk of bacterial infection in patients with cirrhosis caused by multiple factors like liver dysfunction, portal systemic shunting, gut dysbiosis, increased bleeding time, cirrhosis associated immune dysfunction, and genetic factors. So the definition of bacterial infection of ascitic fluid without any intra-abdominal surgically treatable course of infection, that is the definition of SBP, spontaneous bacterial peritonitis, and prevalence is around 1.5 to 3.5% in outpatients and 10% in hospitalized patients, and the prognosis mortality is more than 90% when first described, but with the advent of antibiotics and early diagnosis and treatment, it is reduced to 20%. So now any patient that gets admitted with the ascites, we always rule out SBP in the first instance. So diagnosis is based on diagnostic paracentesis. 50% of SBP episodes are present at hospital admissions, and it may be symptomatic, it may be asymptomatic, particularly in outpatients. So the choice of antibiotic for the treatment of spontaneous bacterial peritonitis depends on the hospital. So usually, because we work in a tertiary care hospital, our initial antibiotic choice is a third generation cephalosporin. And if the patient comes from other hospital, then we might hike up the antibiotics also. But what I suggest, what is the general protocol is, before starting antibiotics, we should always take a culture from the ascitic fluid, so that if the patient does not respond to antibiotics later on, the antibiotics, we can know that the patient has got any resistance to the antibiotics which we have given. But the common antibiotic that we start empirically is a third generation cephalosporin. And the administration of albumin is also recommended in patients with SBP at the dose of 1 gram per, initially you can start at 1.5 gram per kg, followed by 1 gram per kg on day 3. So secondary prophylaxis, as I have said earlier, if the ascitic fluid protein is less than 1 gram, and if the patient has got an initial SBP, then after the correction of SBP, the patient should be on prophylactic antibiotic. The prophylactic antibiotic of choice can be norfloxacin, or it can be a quinolone group of drug, or it can be a cefixime also, that is the cephalosporins also we can give as a prophylaxis for these patients who have once developed SBP, or in which the patient's protein level in the ascitic fluid is very less. So this is a guideline from the European Society, which says that to level these patients and to treat these patients, we should get a baseline SOFA score. If it is available, then you have to apply sepsis 3 criteria. This is the most advanced one, the sepsis 3 criteria. Sepsis 3 criteria involves respiratory rate more than 22, systolic blood pressure less than 100, and altered mentation. Out of these 3, if 2 are there, then we say that the patient is into sepsis. So if this sepsis criteria is positive, then the patient should be admitted in ICU. If it is negative, then it is a good outcome. We can treat in the ward. And also at the same time, we can do a quick SOFA score. Quick SOFA score contains these 3 which I have mentioned. Then coming to the next important complication that we see in patients of chronic liver disease, that is renal impairment. So acute kidney injury and HRS, hepatorenal syndrome. So here there are 3 terms which we should know. One is chronic kidney disease, one is acute kidney disease, and another is acute kidney injury. So chronic kidney disease, we know if the GFR is less than 60 ml per minute, and if the disease is more than 6 months, we label it as chronic kidney disease. Acute kidney disease, if the duration is less than 6 months, less than 3 months. And acute kidney injury, the definition is if there is an increase in the serum creatinine of more than 0.3 milligram per deciliter from baseline within 48 hours, or an increase more than 50% from baseline within 3 months. So first step is to establish whether the patient has got a CKD, AKD, or AKI, or overlap. This is the first step. Now this AKI, again, once we diagnose the patient as AKI by this definition, where it is serum creatinine more than 0.3 within 48 hours, where increase in serum creatinine more than 50% within the prior 7 days, we have to stage the AKI. AKI can be stage 1A, stage 1B, stage 2, where the serum creatinine is more than 2-fold to 3-fold from baseline, and stage 3, where it is more than 3-fold from baseline. Now, this is the treatment algorithm for forwarded by International Ascitic Club for the treatment of AKI and cirrhosis. So initial AKI, if it is stage 1A, close monitoring should be there. There should be we should remove all the risk factors like withdrawal of nephrotoxic drugs, vasodilators, NSAIDs, beta blockers should be stopped, and infection should be ruled out. And if with this, if the patient resolves, then we need to closely follow up the patient. If still it persists, then we have to treat further on case-to-case basis. And if after this also, if withdrawing all the risk factors, also the kidney disease progresses, then we have to withdraw diuretics and start treatment with volume expansion with albumin and see the response in this group of patients. If the patient responds, it's good. If the patient does not respond, we have to see whether the patient has developed hepatorenal syndrome. If the patient has developed hepatorenal syndrome, then we have to treat with vasoconstrictors and albumin. So differentiating types of acute kidney injury, there are 2 types of HRS. Type 1 HRS, the terminology has changed now. Type 1 HRS now corresponds to HRS-AKI, and type 2 HRS includes renal impairment that fulfills the criteria of HRS, but not of acute kidney injury. So International Ascitic Club diagnostic criteria for HRS-AKI is cirrhosis and ascites should be there. Diagnosis of acute kidney injury according to the criteria. If there is no response after 2 consecutive days of diuretic withdrawal and plasma volume expansion with albumin at the dose of 1 gram per kg of body weight, there should be absence of shock. There should be no current or recent use of nephrotoxic drugs, and no macroscopic signs of structural kidney injury like absence of proteinuria, absence of microhematuria, and normal findings of renal ultrasonography. So the treatment of HRS-AKI is, first we give albumin. If the patient does not respond to albumin, we start on vasoconstrictors like terlipressin. Terlipressin initial dose is 1 milligram every 4 to 6 hours, or it can be given by continuous IV infusion. The maximum dose that we can give is up to 12 milligram per day, and albumin should be used at 20 to 40 gram per day. Noradrenaline also can be used in place of terlipressin. And if still the patient does not respond, tips and liver transplantation are further there in the management of this group of patients. And prevention of HRS is, you can prevent HRS by giving, like as we have discussed, norfloxacin should be given to these patients who have low protein, and also albumin should be given to these patients. Now coming to another that is hepatic encephalopathy. So hepatic encephalopathy is a brain dysfunction caused by liver insufficiency or portosystemic shunt. It manifests as a wide spectrum of neurological or psychiatric abnormalities ranging from subclinical alterations to coma. So there are various precipitating factors that we should rule out, like infection, GI bleed, diuretic overdose, electrolyte disorder, constipation, electrolyte disorder, infections, constipation, diuretic overdose, or GI bleed. This is the West Haven's criteria for the classification of hepatic encephalopathy. I'm not going to the details of this, but there are two things. One is covert encephalopathy and overt encephalopathy. Covert encephalopathy is which includes minimal and grade 1 encephalopathy, and overt is the grade 2, grade 3, and grade 4. Grade 4 is of course coma, and grade 1, grade 2, grade 3 we have to differentiate clinically. So overt hepatic encephalopathy or acute confusional state, these are the differential diagnosis. We have to rule out diabetes, alcohol, drugs, neuroinfections, various electrolyte disorders, non-convulsive epilepsy, psychiatric disease. These are all the various differential diagnosis, you can say, or intracranial bleeding also should be ruled out, dementias, brain lesions, and obstructive sleep apnea. Now coming to management of overt hepatic encephalopathy, is initial care of patients, alternative causes of mental status should be sought and treated, precipitating factors should be treated, and empirical hepatic encephalopathy treatment should be started. Like lactulose is the first choice, rifaximin can be add-on therapy to lactulose, oral branch chain amino acids can be given, then L-ornithine, L-aspartate IV has got proven. These are all grade A recommendations by the European Society of Gastroenterology, also by the American Society of Gastroenterology. Neomycin can be given in place of rifaximin, lactulose, and metronidazole also can be used. Now, daily energy intakes that should be, that is advocated is 35 to 40 grams. Now, there is always a confusion of protein intake in this group of patients, that protein should not be given, that will lead to encephalopathy. But let me make it very clear that daily protein intake should be should be around 1.2 to 1.5 gram per kg per day, because if you restrict protein intake, not good in those group of patients who are cachectic and who have sarcopenia. So small meals or liquid nutritional supplements evenly distributed throughout the day, small frequent meals and late night snacks should be offered, and oral branch chain amino acid supplementation also should be given to these patients. Now, another term, relative adrenal insufficiency. Now, all of us might have seen these patients of chronic liver disease. Once they are in CTP B or C, they have hypotension. Now, what the cause of hypotension can be sepsis, but if you have ruled out sepsis and also in this group of patients, the other thing that is newly come up, there are studies, is adrenal insufficiency. Now, this group of patients who have CTP B or CTP C, they have this relative adrenal insufficiency. Their studies have proven this, but whether this group of patients should be given steroids or not is not clear. It's not yet recommended, but the European Society also says the hydrocortisone treatment cannot be recommended at present. But case to case basis, if you see the patient has having hypertension, you can give low dose of steroids. In like hydrocortisone, we give 50 milligram twice daily or thrice daily, and you can see whether the patient improves. Now, I am almost coming to the end of my presentation. Now, only a few slides left. That is the cirrhotic cardiomyopathy. This is also another common, and let me tell you the practical point of this, because sometimes whenever we see a patient of decompensated chronic liver disease, our tendency is to give albumin. And we have seen many patients dying after giving albumin if you give albumin fast, or sometimes you might have seen that after giving albumin, the patient develops cardiac failure. Now, all patients don't develop. Now, those patients who have cirrhotic cardiomyopathy, they are prone to develop this cardiac failure due to albumin. So cirrhotic cardiomyopathy is a common condition which needs to be ruled out. There is a blunted contractile response to stress, altered diastolic left ventricular relaxation. There can be increased QTc prolongation, and also there can be cardiac output tend to decrease with decompensation, and there can be systolic dysfunction also. And it is largely subclinical, but is present, influences prognosis in advanced disease and also the transplant outcome. So those patients who have cardiac decompensation, their tips insertion becomes difficult. thing. And also, if we want to give some drugs which can prolong the QT interval, then this group of patients, we need to be careful. So we should we should be careful of this terminology called cirrhotic cardiomyopathy. Now, again, one important thing is hepatopulmonary syndrome. So hepatopulmonary syndrome, it encompasses 4 things that can happen with chronic liver disease. That is pneumonia, hepatic hydrothorax, hepatopulmonary syndrome, and portopulmonary hypertension. Now, hepatopulmonary syndrome is defined as a disorder in pulmonary oxygenation due to the opening up of shunts or intrapulmonary vasodilatation. And it's in the clinical setting of portal hypertension. And these patients, they usually have dyspnea and platypnea. Platypnea means the patient has got dyspnea on the patient. Normally we know orthopnea, that is the patient has got respiratory distress when the patient lies down, but here the patient has got dyspnea when the patient is upright position, that is known as platypnea. So this is the pathogenesis of hepatopulmonary syndrome. I'm not going to the details of this, but the main pathogenic mechanism is increased endothelin release, which causes increased eNOS, nitrogen oxide, nitrogen synthase activity, which causes vasodilatation. And this vasodilatation opens up shunts, that is angiogenesis due to the endothelial cell stimulation, and also due to increased nitric oxide release and carbon monoxide release. And this vasodilatation causes pooling of blood in these dilated vessels, which causes congestion in the lungs and shunting of blood, which can cause respiratory distress to these patients. Now, the diagnostic criteria is the patients will have a hypoxia with partial pressure of oxygen less than 80, and the alveolar arterial oxygen gradient is more than 15. So it's commonly in presence of portal hypertension, in particular hepatic portal hypertension with underlying cirrhosis, and pre-hepatic and hepatic portal hypertension in patients without underlying cirrhosis. So the diagnosis is by the use of contrast echocardiography. And also another thing is macro aggregated albumin scan, which is a radionuclide scan, technetium scan, which can be done to show the degree of shunting in patients with severe hypoxemia and coexistent intrinsic lung disease to assess the prognosis in patients with HPS and severe hypoxemia. Pulmonary angiography also can be done, but it's not required. Usually our clinically and most practical thing is to do a contrast echocardiography and diagnose hepatopulmonary syndrome. And management of hepatopulmonary syndrome is liver transplantation. And these patients who require liver transplantation, sometimes they require long-term oxygen therapy even after transplantation. And severe hypoxemia is associated with increased post-liver transplant mortality. So sometimes if the patient has got severe hypoxemia, then transplant outcomes also is not good. And if the transplant is also done, these patients have to be in long-term oxygen therapy. Now, coming to the last topic, that is portopulmonary hypertension. This is development of pulmonary arterial hypertension in patients with cirrhosis. It can be mild, moderate, or severe. If it is mild, if it is more than 25 but less than 35. Moderate if it is more than 35 and less than 45, and severe if it is more than 45. And this incidence is between 3 to 10% of cirrhosis patients based on hemodynamic criteria. Women are at 3 times greater risk and is more common in autoimmune liver disease. There is no clear association between the severity of liver disease or portal hypertension and the development of severe portopulmonary hypertension. So I think this is the last slide. So monitoring and medical management of portopulmonary hypertension, beta blockers should be stopped. This is the most important thing. If patient has developed portopulmonary hypertension, if there is pulmonary arterial hypertension, then beta blockers should be stopped, and this group of patients should be treated. Varicose bleeding should be stopped by endoscopic therapy. And the screening for this is this can be diagnosed by transthoracic Doppler echocardiography. And in patients who have a positive screening test, right heart catheterization can be done to measure the pressures. And therapies approved for primary pulmonary arterial hypertension may improve exercise tolerance and hemodynamics in portopulmonary hypertension. Our endothelin antagonist should be used with caution, and TIPS, this is very important, TIPS should not be done in patients with portopulmonary hypertension, because once we do TIPS, the pressure in the right side of the heart increases. This will further aggravate portopulmonary hypertension. So in short, this was about the management of chronic liver disease, and basically I have discussed the management of decompensation of chronic liver disease, and I have not purposefully discussed about the etiology of the chronic liver disease, because the etiological factors we know, and the treatment of all the etiological agents is also of paramount importance. So thank you all. Thanks.
Thank you very much, Dr. Sandeep Paul. And it is now my pleasure to invite Dr. Sanjay K. Goja. So before we go on to the panel discussion, we'll listen to Dr. Goja and then we'll go to the panel discussion. So Dr. Goja, please. Dr. Goja, please unmute yourself.
Yeah.
Sure.
Are you able to listen to me?
Yes.
Yeah.
We can hear you.
Yeah. Are you able to see the screen? Share my presentation.
Not yet.
Okay. I just. Can you see now?
Yes, we can.
Yeah. Good evening, everybody, and esteemed faculty here, Dr. Sandeep, Guru, all Dr. Mamoon, and thanks very for giving me opportunity to give a talk here. What essentially I will talk about is the liver transplantation. When should a liver disease patient be taken up for the liver transplant, or counseling for the patient should be done for the liver transplantation? And also I will just
Dr. Sanjay Goja, please press slideshow option.
Okay. Is it okay?
Okay. Yeah, it's okay.
So, I mean, the liver transplantation started with this guy, I mean, great man. He died last year. And we have so in regard that he introduced the liver transplant across the world. Everybody knows his name, Starwell, and he's related to the first transplant. He showed us the road to the treatment of the liver disease who are decompensated and who have very short span of the life. Essentially, the liver transplant encompasses the three things. One is we have to evaluate the patient. Second is what are the indications, and most importantly, what is the contraindication when we should not offer transplant to the patient. The etiological evaluation needs to look at the liver disease from the perspective of its etiology, chronicity, decompensation, as well as we have to look at whether the transplant is going to increase the lifespan of the patient and give a good quality of the life to the patient. We cannot do offer a transplant to a patient who we think that his performance his status is so weak that his quality of life may not improve after liver transplant. So these all things go in the evaluation of the liver transplantation. The indications, as Dr. Sandeep Paul told, there are a number of indications. Among them is all the causes of the chronic liver disease. Then we have tumors of the liver. Then we have acute liver failure. Contraindication is there are essentially four essential contraindications. The most important is somebody is carrying active infection at the time when you are considering the transplant, we don't do transplant. Or there is the quality, this performance status of the patient is so poor that transplant is not going to increase his lifespan. Or there's a disease process even after transplant that the life expectancy of the transplant will be anyway short, irrespective of giving liver transplant to the patient. Suppose patient has severe portomesenteric thrombosis. We are not going to essentially, when we do transplant, there will be no nothing we can do that to increase the lifespan of the patient. So these are the essential contraindications of the transplant. So transplant has to be looked in the two way. One is the equity and other is the efficiency. Whenever we consider transplant of a patient, it has to be seen from two angles: equity and efficiency. Efficiency meaning that need for the transplant so that it gives a good quality of life post-transplant and there is a high chance of survival post-transplant. We cannot offer transplant to a patient who has low chances, like somebody is carrying infection. At the same time, if we be equitable, then there's a probability we may give liver to the some patient who is a very poor performance status. Like this very sick patient, we will give the liver. So we may the graph we may lose that the utility will go down. So this balance has to be kept there, the maximum efficiency as well as an optimal equity. So why we need to look at this? That is why we need to look the liver disease from the perspective of its course. We need to see the liver disease, whether it is compensated, whether it is decompensated, whether the person really needs a liver transplant or he can be managed medically. As is shown that it goes by the process over the time. And if we see, as Dr. Sandeep has told, there are etiologies, then whether it is viral, whether it is alcohol, whether it is autoimmune, whether it is cholestatic liver disease, metabolic disease, they incite an inflammatory damage to the liver, where there is increased matrix presentation, angiogenesis, fibrosis, and over the years, then they disrupt the architecture of the liver function, and the liver function goes down. And in the process, three things happen. One, liver goes fibroid, goes cirrhotic. A person develops such features of chronic liver failure. He develops a total hypertension. And in the process of this fibrosis, neogenesis, and angiogenesis, there is a high probability of developing cancer in these patients. So there is the chances of developing the HCC. So it has to be, the liver disease has to be seen from the three angles: liver failure, total hypertension, and development of the HCC. So as Dr. Sandeep said, there are stages. It's not that somebody has a liver disease, we just jump to that. It has to be decompensated liver disease. Stage 3, stage 4, stage 5, and beyond that, which really, if we want to optimize the donation, organ donors, they are the ones who need the liver transplant. The rest of the patients, we can wait. They can be on the medical treatment. They can be followed up on the treatment. How we do that, the symptoms, the stages, the venous pressure gradient, and over the time follow up of the patient. So this is the algorithm where you see when you develop variceal hemorrhage, you develop ascites, you develop encephalopathy, the ascites particularly, which is not controlled, jaundice, and then later on you develop HRS, HPS, SVP. Then they are the candidates who should be told that to go for the liver transplantation. Why they should be told for the liver transplant? As you see, the death rate at 1 year goes, as the stages go high, the death rate goes high. It from stage 1 to stage 3, 57%. So if we don't offer transplant, at the end of the day, there is 57% chances that he may not. It is the normal course which a liver disease, chronic liver disease today. Sometimes it may be compensated, but there is some event which tilts the balance towards the decompensation, what we call as acute and chronic failure. As we have seen a lot of ethanolic patients who are well compensated. Suddenly they develop hepatitis A infection, superheated hepatitis E infection, or they develop bleeding, or they acutely decompensate, what is called acute and chronic liver failure. So it may not be the process which goes slow over the time. The balance can be tilted earlier also. We have to keep when that balance, acute and chronic liver failure, because of any reason, the person goes into multi-organ failure, coagulopathy, liver, it affects all the systems, it becomes a multi-organ disease. They are the ones who need early transplant. We can wait, but they are the ones who should be counseled that time they need to have early transplant. So how we assess, you all are aware that there are, MELD score, CTP score, Cliff-Sopa score. These are the scores of assessing the severity of the liver diseases, the MELD score and bilirubin, creatinine, INR, and all. I think you are all well versed with these scores. Essentially, they tell us what is the severity of the liver disease. So how, if we take the CTP score, if we see the mortality at 1 year and 2 year in different classes of the child CTP scores, you will essentially see that as you go down to the CTP score of the C from A, the mortality at 2 years is quite high. How do they fare? If you see, essentially, there is not much difference between the two in predicting sensitivity and specificity of these. If you say ROC curve, they're essentially same. Only thing is, MELD makes it more objective assessment. The CTP score is a dynamic. The things may change. The grade of encephalopathy may change. The person who assesses him, the grade of may change. So they essentially are saying that is why MELD score is incorporated in the listing criteria, because it is a more objective and it more tells us about how the patient is going, the mortality, waitlist mortality. Then the other indication being the acute liver failure. I will not go into the what stage, but you see there are many criteria. The commonest we follow is King's College criteria, and then there's the French criteria and Japanese criteria. The King's College criteria, we know there are something like age, cause of the disease, like if you have hepatitis A, you are likely to improve. Rate of encephalopathy, bilirubin level, and coagulopathy. In Clichy criteria, we see the level of the factor 5 and the Japanese criteria, the different criteria. What essentially is King's criteria, the paracetamol, non-paracetamol. What is more relevant to us is non-paracetamol. It shows that when you have somebody INR at more than 6.5 or any of the three criteria, which I think you all are well versed. Essentially, if a person has non-viral, the chances of him improving conservatively are less. How we differentiate also encephalopathy, what we have seen most of the times. I mean, we get these patients like rat poison patient, and we have seen that INR coming to very high, but we saw that they don't need transplant. What we look at is there is essentially the encephalopathy. There's some differences between the acute liver failure encephalopathy and due to the chronic liver. It is a sudden onset. We must understand it is mostly related to the brain edema. Brain edema is essentially leading to herniation, which is the cause of the mortality in acute liver failure. The encephalopathy in acute liver failure, if it is grade 3, grade 4, which needs intubation, it carries a poor prognosis, and those are the patients who need the liver transplant. And as Dr. Sandeep already told you, there is another indication is hepatorenal syndrome. Hepatorenal syndrome is basically the mechanism is like splanchnic vasodilation and renal vasoconstriction, and it is manifested in HRS type 1 and type 2. And over the years, it has been changing all the time. Every year we have new this thing coming. But essentially, when somebody develops the HRS, you have to think that we have to think of the transplantation, because without transplant, their mortality at 6 months is quite high. And if you have HRS type 1, which is Dr. Sanjeev HRS-AKI, which is now called at the when you are out of infection, but the transplant should be offered as soon as possible. Then is the hepatopulmonary syndrome. Essentially, it's not everybody who has a hepatopulmonary syndrome that the treatment of choice is liver transplant. But if a patient is coming with if his PaO2 is more than 60, and even if the atrial, the alveolar difference is more than 50 millimeters, you can follow up and keep seeing that patient. But once it comes less than 60, and then we have to think the early transplant, because what happens in if you wait, as Dr. Sandeep said, the post-op mortality in the liver transplant goes high, because then irreversible changes set in the pulmonary circulation and pulmonary alveoli, and the hypoxia post-op may not improve over the long period of time. And what I have seen, many of these patients in the post-op period usually develop intracranial hemorrhages. That is some peculiar thing which happens in these HPS patients who keep on waiting over the time. It's a long duration HPS, the saturation is very low, then they develop intracranial. So prognosis of the liver transplant goes down as you keep waiting. So essentially summarizing all these things together, from the liver transplant perspective, we have to see how much is the wait time. When should we tell the patient that he needs a transplant? What should be the time interval between when see the patient and how much time he has to, so that he doesn't become so high risk, where the utility of the graft is lost, where the utility of the transplant is lost. So if you see ALF, the time is very short. In ACLF, it is little longer, but it is still higher. And in the chronic liver disease, it is quite long, and we can usually we offer transplant to the patient whosoever has a MELD score more than 15, and it is quite long. The red zone comes when the outcomes are very poor after liver transplant. So we have to make sure that during this period only they should be offered the transplant. One of the indications of the liver transplant, which is very interesting and which has come in the new, and there is a whole branch of transplant oncology coming up, is liver cancer. Earlier we thought of the transplant only of the HCCs. Now the transplant is being offered to cholangiocarcinomas, intrahepatic cholangio, colorectal mets, neuroendocrine tumors. So development of the HCC is a very peculiar thing, because person may not be decompensated, but once you develop HCC, so what should we offer? Should we offer a resection? Should we offer a liver transplant? It all depends on how much portal hypertension is there, how much liver function is preserved there, and how much reserve he has, and how many liver tumors are there, and is liver transplant going to increase the at least 70% 5-year survival. That may not be disease free, but at least this should be a benchmark for that. So the liver SCC, as we know, it can develop at any stage of the once you develop cirrhosis. How we screen these SCC patients, all of you know that the normal thing is ultrasonography every 6 monthly without alpha fetoprotein, with cutoff of 20 alpha fetoprotein, and the lesion, when it is more than 10 mm 1 centimeter, the patient is undertaken for more imaging like triphasic CT or contrast MRI, and their findings are interpreted in the form of LIRAD scores. The LIRAD score is the radiological assessment of the and data analysis score, and we, according to that, we usually classify it from LIRADS 1 to 5, and below LIRADS 1 is LIRADS NC, and beyond then is M. Essentially, LIRAD 1 and LIRAD 2 are usually non-HCC. I mean, they are benign tumor, like your human tumor, your contrast enhancement, but it's not washed out. LIRAD 3 is like we have a doubt. There's a contrast, there's atrioportal fistula. You think that there's enhancing nodule in there, but we're not very sure. So that may need repeat after 3 to 6 months. Once your LIRAD 4, it may be enhancement. There may not be portal washout. These are the patients who need liver biopsy. If you have a LIRAD 5 score, that is essentially, it is a diagnostic of SCC. We don't need to get a biopsy done. The person can directly go to whatever other surgery, TACE, or liver transplantation. And if your LIRADS M is like cholangiocarcinoma, it is a late enhancement of the tumor on the contrast imaging, then those people also need biopsy of the liver. Actually, this chart, all of you are aware, it comes from the generations from the Barcelona clinic. It essentially tells you, although it has changed, it tells you the HCC treatment depends on not only the size of the tumor, liver function, as well as the degree of the portal hypertension and number of nodules. And if essentially liver transplant is how, if you have less than 3 nodules and less than 3 centimeter and liver is cirrhotic, performance is good, then we offer the transplant. Although this does not strictly apply because of the living donor transplant, because across the centers they have extended the criteria. Essentially, the commonest criteria, which all of us know, the Milan criteria, single tumor, less than 5 centimeter, and or 3 tumors up to 3 centimeters. This is the classical one. Mazzaferro became 3 centimeters, and it was extended to. There are a number of criteria which extended that. But if you look at those criteria, you come down that Toronto criteria, total liver volume criteria, Coito criteria. The disease-free survival at 4 years comes drastically down to from the Milan criteria 92% to 68% to 30% to 30%. So it's the disease-free, although they may have good more than 50% 5-year survival, which is required for to undertake the liver transplant, but disease-free survival goes down. And it is essentially said what Mazzaferro said, it's a metro ticket. The more you travel, more you have to pay. The longer the trip, the higher the price. The more you extend the criteria, the more you have to pay. There will be higher recurrence. So how we see this balance of equity versus urgency in HCC for with cirrhosis. Normally, cirrhotic patient, whenever we do the transplant, they are usually high melder, they are sick, and they have high pre-transplant mortality. But when we see HCC with cirrhosis, they are not decompensated, they are well, they will come walking, there is no ascites. So it becomes essentially, what should we do with this patient? Should we offer TACE? Should we do resection? Should we do transplant? So it has to be on the utility base. And when you are offering living donor liver transplant to this patient, it essentially boils down to the family, who we have to explain what are the pros and cons of doing resection versus transplantation. What is the risk of decompensation if we do the resection in case of cirrhotic patient? Obviously, if it is child C or late child B, he goes directly to the transplant. But if it is child A, early child B, it is always a contentious area where whether we should have a transplant, whether we should have a resection. So essentially, if you have non-transplant treatment, early on, it gives a good benefit. But when you have a later stages, it is the transplant which gives a better, which is a more gives more utility. So HCC the transplant gives advantage. I mean, it's a multicentric. It is a fertile soil. There are multiple nodules may be present. So it prevents the wreck runs. Underlying cirrhosis or it hits the two diseases at the same time and gives a good widest oncological clearance. But what is our criteria and what is followed is the ASAN medical center across the Japan, because we have living donor liver transplant. It essentially boils down to the patient family who will always say, we want to save our relative. So our criteria is there should be no extrahepatic disease, there should be no vascular invasion, main vascular invasion, no, there should be no contraindication to transplant itself. Suppose somebody has Pathopulmonary hypertension severe, so you can't do transplant in those cases. And we don't look at the tumor site. Obviously, preoperative, we don't biopsy them, we don't know about the biology. Then there is something like salvage transplant. I mean, this is well tested. It's the proponents of the salvage transplant, we resect the tumor. Then we subject it to the pathology. Then we know how much. How much what is the prognosis of the hello, am I audible?
Yes,
yeah,
you are audible. Please continue.
So the salvage transplant, once you do resection, after that you subject to the transplant and you know the biology of the tumor, you can prognosticate the tumor. But unfortunately, if we go to the studies, we show intention to treat therapy, the disease-free survival after salvage transplant is usually inferior to the primary liver transplant. But otherwise, if this option is there, that can be equally offered to the patient. This was about HCC. Now, over the years, the liver transplantation has the criteria for extended to others. And one of the commonest indication has been of the neuroendocrine tumors. The neuroendocrine tumors, the simple is if you can take out 90% of disease, you do resection. If you cannot, offer transplant. Even in spite of you have primary lesion, as I'm showing here, primary outside. I have done transplant where patient had pancreatic head lesion, jejunal lesion. We did a liver transplant, patient 5 years, absolutely all right. The indication transplantation to neuroendocrine tumors and other tumors like cholangiocarcinoma. The cholangiocarcinoma, it started with the Mayo protocol. Although this Mayo protocol, the results were good, but it could not be replicated in other centers. So that hilar cholangiocarcinoma, it still is a doubtful entity. But intrahepatic cholangiocarcinoma, nowadays, they have started offering with good results. And one of the new things which come from the Norwegian people, they have a big study from Norway where they have offered for the colorectal, they have high donation, cadaveric donation, they have offered to the colorectal mets which are not resectable. And they have shown a good 5-year survival. It is coming up, and within 4 or 5 years, we will have the exact data whether we should be, if this liver transplant should be offered to the patients of the colorectal. It is still in the investigational phase. So this was about who should be offered transplant, when should be offered transplant. Now coming down to what are the types of the transplant. Essentially, you all know it all depends on donor organ. It can be deceased donor transplant, it can be living. This data is from the UK, so the figures may not replicate to ours. It is other way around. We have 10% cadaver transplant, 90% we have living donor liver transplant. I mean, deceased donor transplant, it can be brain dead transplant and DCD transplant. Brain dead transplantation is usually which is applicable to our part of the continent. This DCD is usually in Scandinavian country. It has picked up very well there. See, essentially, it is a brain donation after brain death, where the brain injury has caused loss of consciousness and capacity for respiration, and their patient is neurologically not recoverable. And it is confirmed by the neurosurgeon, neurologist that his neurological status cannot be recovered. And circulatory death, the DCD is where person has a neurological, but he has intact reflexes. The family is prognosticated that he may not recover. So we have to subject him to support all the supports. respiratory and cardiac support. So it is a controlled donation. Sometimes it's uncontrolled. There are 4 Maastricht classification. So then it can be controlled, it can be uncontrolled. But it essentially boils down to the family, and it develops on the legal system of the country where the DCD transplantation. There are some hitches in the DCD transplant because the results of the DCD transplant are not good as the brain dead transplants, which have been shown. I will just discuss in the meantime. The liver transplant, especially a living donor, deceased donor can be, we can give whole organ to the patient, we can reduce the patient. Living donor is, we cannot give whole organ, it has to be one lobe of the liver or a part of the liver. So I just told that brain dead, they are neurologically dead, where circulate, they are not neurologically dead, but the family is consented, they want to withdraw the support, and then we take the donation. But what is the problem is that when you take off the support, and you have to give time so that his all arrest happens. Sometimes it takes time. So there's a warm ischemia time initially. That warm ischemia time is one which affects the graft in the DCD. In brain dead, it starts directly from the cold preservation, and then you have during the implantation second warm ischemia. Whereas it has a long warm ischemia time, that warm ischemia usually affects the biliary tract system. So we have the patients in the post-op have a lot of biliary complications, and the results have come down. But because the DBD donor wait list is very high, if you see overall from the intention point of view, the results of the DBD in the patient survival may be lower because of the high pre-transplant wait list mortality. What is the cause of this DCD? This is a lot of biliary complication because we have a warm ischemia time. We can have a split liver transplant. We can split the organ in the because of the two, and we can put the two organs together. This is just a depiction that we can use a whole organ, or we can split the cadaver organ in there, or we can use a piece of it, put in a child. It's called left lateral segment. Living donor is totally different ballgame. Living donor is a donor who is willingly, who is between 18 to 15, whose liver is well. He has to have an adequate remnant, about 35%. His liver has to be fat-free, less than 20% of steatosis. He should be healthy with no comorbidities. What makes living donor liver transplant is depicted in this tree diagram. It came in the journal of hepatology. Basically, the surgical part becomes very difficult. You have to basically divide between these branches, which makes living donor liver transplant little complicated. How it started, I just want to go a little history. Liver transplant as such did not come from living donor. It had a long history. It all started in Brazil, where they did first biliary atresia patient, and he developed hemolysis and died. And in 1989, they another did one. His bilirubin went to high, and he didn't survive. Ultimately, the successful liver transplant was done. Living donor was done by Russell Strong in Australia on a Japanese boy. Japanese boy whose 29-year-old mother gave the organ. Because this Japanese guy was not eligible to get deceased donor in Australia, he had only one option to get a living donor. That is why he was forced to do living donor transplant. And 40 days after, the patient went home. And then came the left lobe grafts from the Japan. They started doing initially for the safety of it. They went to left lobe grafts. The first right lobe graft was done accidentally. It was in the Japan, they took for the left lobe, but when they were operating during the surgery, the arterial anatomy was so difficult for the left lobe, they had to go for the right lobe. This is how the right lobe donation started. And immediately after that right lobe, Russell Strong, who had done first living donor liver transplant, was very critical of this. He issued the three things in the living donor, which still I think hold true. We must demonstrate the need for the procedure. Person, a liver disease should have a need for the liver transplant, then only we should do. We must assess the benefit. It should give a good quality and good survival to the patient. Then only living donor should be. And we should have a full informed consent. And we have to make sure that donor safety takes the priority in living donor liver transplantation. Living donor liver transplant, you can have a right lobe, you can have a left lobe, you can have a left lateral segment. It all depends upon the volume, weight of the patient, his size of the patient. Normally, we take GRWR of 0.8. GRWR means the weight of the graft, which is by volume analysis during the CT volumetry to the weight of the recipient, and optimal has to be 0.8. this is the living donor. Sometimes the portal pressures are high. We do bypass of the some portal flow so that the graft is not hit. This is all evolution of the liver transplant. Slowly it has extended, and slowly the more complex procedures have been added to it. And then liver transplant in children as a special place. If anybody should be offered urgent transplant, that is a pediatric transplant, because they have an excellent survival, excellent outcome across the world. The survival is more than 90% for the pediatric transplant, and they need only a little piece of liver from there. If you see, we just reduce the liver, put a just little bit, and after the perfusion, you see how the liver looks. So it is a life-saving procedure for the kid. Sometimes you may not do whole liver, you do just part of the posterior part of the liver, only little part of the, you lead most of the liver to the donor, give a little part of it. Sometimes when the patient is big, you need to give more liver. You can have two donors, what is called as dual lobe graft. You can put part of liver from one part of liver, that's called dual lobe graft. Sometimes the group is not matching. We may do swap. There will be swapping with the other couple. There may be volume swapping, whether there is inadequate volume. One patient's donor has a good liver volume, he fits the recipient of one. Other has a low volume, he fits the other. So it can be volume swap or a group swap. And one of the transplant types, although I didn't want to put it as auxiliary liver transplant, it is usually done in acute liver failure, where usually we give time for the native liver to, in the meantime, we support it by putting a little liver graft there. It gives us support during the initial period when the acute liver failure initially after recovery. It is called auxiliary partial orthotropic liver apult, it is called. It can be orthotropic or heterotropic. Then there's one called domino transplantation. It is a very good concept because many children need liver transplant, not for the liver disease itself, for the metabolic liver disease. They have this enzyme deficiency, and what of the enzyme is synthesized in liver. If we put this liver into other recipient, is a normal liver who has normal synthesis of this enzyme extrahepatically, this liver will act for him as a normal liver. At the same time, he gets a liver from other cadaver or the donor. So we have one liver, we have two recipients. This is a very important thing and very useful policy if somebody is carrying metabolic liver disease, especially in the children. Now, coming to the last, Dr. Mahmood, now you see one of the things in the donor is the cosmetic, and especially for the mothers. What I usually offer is doing the minimal access surgery for the mothers of the children, the pediatric baby, they left lateral graft, because they have to take care of their child very soon, and they have to nurse them also. So what we want, that they should not have incision, they should not have a lot of hospitalization, they should go away very early. So now I'm doing all the pediatric donors robotic surgery. This is our setup of robotic surgery, doing robotic hepatectomy. This is how it looks in the robotic hepatectomy. Doing this is the donor. We did left lateral, and this is me. This is one of the donors. You will not believe, this is 5 days post donation. She is like this only. I specifically put her on. This is what gives the minimal access approach to the donors. She is healthy, smiling. As soon as the child gets discharged, she can hold the child in the lap, nurse him, and breastfeed him. This is the beauty of doing robotic and minimal access, especially in the mother. And last of all, these are our centers, Ardic, Bangalore, and Delhi centers for transplantation. And I will finish the same with the Thomas Starder's saying that we may be doing great job, but we have to thank the patient who gave us opportunity to exercise this and to apply this all to them. Thanks a lot.
Thank you, Dr. Goja. We have learned a lot from your two lectures, and especially this robotic surgery is something very new to me. I have not seen something like this before. So now it's time.
Dr. Mamun, you are not visible.
Sorry. This modern technology, you don't know how many things to click and how many things to wear and open. You know, we often get confused. Anyway, now going on to the panel of experts. First, it is my pleasure to invite Dr. Daliluddin. Dr. Daliluddin is an assistant professor of hepatology at Kumilla Medical College. Dr. Dalil bhai, if you please give your comments on today's talk. Dalil bhai, your fan is visible. You are not. Yeah.
হ্যালো
হ্যাঁ দলিল ভাই বলেন।
হ্যাঁ হ্যাঁ আসসালামু আলাইকুম
জি
thanks to honorable speaker. I am also giving thanks to my teacher, moderator Professor Mamun Al Mahatab for selecting me as a panelist. Are you looking me?
we can see you partially. Now we can see you fully.
And fully?
Now it's perfect.
Yes. Chronic liver disease is a lifelong suffering condition for the patient. If we cannot give them the permanent treatment like liver transplantation, cost of the liver transplantation is higher, but not so much as compared to the distress of life and long-term medical treatment. But it is a matter of regret that although about 60 years passed as liver transplant done in the world first 1957, but in our country we cannot do it well. But in our neighboring country is doing good in this respect. I will be very glad if our speakers, especially from India, do their level best for establishing a liver transplant center in Dhaka with collaboration with Delhi. Thank you, all the audience and speakers and moderator for giving me the chance. Thank you. Assalamu alaikum.
Thank you, Dr. Daliluddin. It is now my pleasure to invite Dr. Asaduzzaman, Assistant Professor in Head Department of Hepatology at Mugda Medical College in Dhaka for his expert opinion, please. Dr. Asaduzzaman. Asad, please unmute yourself. You are muted.
Thank you, sir. Can you hear me, sir?
Yes, we can hear you, Asad.
Yes. So at first, I thanks the moderator, Professor Mamun Al Mahatab Shopil sir, for giving me the chance as a panelist of this session. This session is very niceful, and I also thanks to both the speaker. They give very much informative for liver transplantation. In our country, we are lag behind the liver transplantation. Most of the patients we treated as conservative. But I hope in near future, with the help of Professor Mamun Al Mahatab sir, we can be arrange liver transplantation successfully in Bangladesh. A lot of patients where I practice in Naranganj are waiting for liver transplantation. 2 or 3 patients now waiting for liver transplantation to go to India, but in COVID situation, they cannot go. I think the situation will improve and they will take the opportunity of nice liver transplantation like robotic surgery. Lastly, I thanks the organizer, the Beacon Pharmaceutical, also Narayana Health, and thank you everybody. Thank you, sir.
Thank you, Dr. Asad. It's now my pleasure to invite Dr. Muhammad Saidul Haq, Assistant Professor of Hepatology at Tajuddin Ahmed Medical College, Gazipur, for his expert opinion, please. Dr. Saidul.
Thank you, sir. I would like to thank you, sir. I am Dr. Mohammad Saidul Haq, Assistant Professor of Hepatology, Shahid Tajuddin Ahmed Medical College, Gazipur. It is my pleasure to attend the session, and I would like to pay my thanks and gratitude to my mentor and honorable teacher, Professor Mamun Al Mahatab Shapni sir, to arrange such a nice and informative and knowledgeable session. And I would like to give thanks to the honorable speakers, Dr. Sandeep Pal and Sanjoy K. Goza, for delivering their excellent speech regarding chronic liver disease and regarding liver transplantation. Nowadays, we are practicing in different areas of Bangladesh, and we are facing very difficulties in treating decomposed liver cirrhosis patients, and at the end, they need liver transplantation, but there is a now in our country, the infrastructure is going on to deliver the liver transplantation in near future. I like and I will hopeful that in near future we will able to do the liver transplantation in our country. So the patients of my country will benefit from this, and they will do the liver transplantation in low cost. And Professor Mamunal Mahatab Shopni sir, as mentor and of us and many of his students like me, we hope that he will do the necessary aspects and to arrange liver transplantation in Bangladesh. And again, I like to give thanks and gratitude to all the audience and the organizer of this session. And thanks to all. Thank you.
Thank you, Dr. Saidul Haq. It is now my pleasure to invite Dr. Abul Hayat Manik, hepatologist at Dhaka Medical College, for his expert opinion, please. Dr. Manik.
Thanks, sir. First of all, thanks to Professor Mamunal Mahatab sir for giving me the chance to say something here. Then thanks to both the speaker, Dr. Sanjoy K. Goja and Dr. Sandeep Pal. I was met with the Sandeep Pal in 2018 at your Narayana Health Center during a workshop on endoscopy. Then he conducted a very nice endoscopy workshop that was very helpful to us. And I'd like to say that this lecture was very much helpful for us. That will enrich us, and liver transplantation lecture by Dr. Sanjoy K. Goja was a nice bit for us. That will help to select a patient with the liver transplantation. First of all, I would like to thanks to the Forum for the Study of the Liver, Hepatology Alumni Association of BSMMO, and Narayana Health Center, and then lastly of all, People Pharmaceuticals for arranging such a program. Thanks to all. Thank you.
Thank you, Dr. Manik. Now, Dr. Debraj Malakar, hepatologist, is working in Manikganj, Munshiganj. So, Dr. Debraj Malakar, if you please give us your expert opinion, please. Debraj, you are not audible.
Dr. Devras, your microphone is not working. Your headphone is not working.
Now can you hear me?
Yes.
Yes, we can hear you.
Thank you. It's a
Debraj will have released.
So, are you hearing me?
Yes, now
It's a yeah. It's a good.
We cannot hear you, Dr. Devras.
Still, you are not hearing me.
Now I am hearing you.
Come front, Debraj. Come front.
Dr. Devras, we are unable to hear you. Hello.
Can you hear?
Yeah, yeah.
Yes.
Now we can hear you.
Repeatedly facing the problem, technical problem. Anyway.
Okay, we can hear you now.
No. Can I start now?
Yes.
Yeah.
It's a great honor for me to be a part of this webinar, where my mentor, my teacher, Professor Mamun Al-Mahatab Shopil sir is present. And he is the iconic figure of medical science in Bangladesh, because he has created much more encourage on the field of hepatology among the students, postgraduate student, graduate, even in undergraduate level. Dr. Sanjay K. Goja, Director and Clinical Lead of Transplant Surgery, Narayana Health, a robotic surgeon, efficient robotic surgeon. Sir has presented his presentation very nicely, and I think all the audience has benefited from his lecture. And Dr. Sandip Pal, he is actually familiar to me. I had the opportunity to have some conversations over email in 2018 for a training purpose in third space purpose. He also presented his topic nicely. Actually, we're the physician fighting always against the disease to gain our fighting by treating and prevention. And we fight by prevention, and prevention. That is chronic hepatitis to advanced fibrosis, and prevent advanced fibrosis to cirrhosis, and then cirrhosis to decompensated cirrhosis. Anyway, both of the speakers are excellent. I think all of the audience obviously benefited from this lecture. Thank you, sir.
Thank you. Next, it will be Dr. Abidul Rahman Jimmy. He is resident physician at Shoaib Nazrul Islam Medical College in Kishoreganj. May I ask Jimmy for his opinion, please?
Good evening. Are you am I audible?
Yes, Jimmy, we can hear you.
Thank you so much. Thanks a lot to our honorable two guest speakers, and thanks a lot to Dr. Sandip Pal, consultant intervention gastroenterologist and hepatologist, and H. Rabindranath Thakur Intervention Institute of Cardiac Science, Kolkata, for his brilliant and informative lecture on updated management of chronic liver disease and its complications like ascites, renal impairment, liver imbalance, hepatic encephalopathy, peripheral bleeding management, SBP, and Hepatopulmonary syndrome. And also thanks a lot to Dr. Sanjay K. Goja, Director and Clinical Lead, Senior Consultant, Head of Liver Transplant, Hepatobiliary and Pancreatic Surgery, Narayana Health, India, for his and informative presentation on liver transplant. And here we can learn how to evaluate a liver transplant patient and indication and contraindication. What is the importance of equity and efficiency in liver transplant and types of liver transplant? What is a prospect of robotic liver transplant? I would also like to express my heartiest gratitude to my mentor, Professor Mamun Al-Mahatab sir, for giving me the opportunity to share my opinion in the and last but not the least, thanks to Beacon Pharma and RAS TV for arranging such a time-demanding webinar on liver transplantation, on chronic liver disease management, and also we are very much benefited from your lectures, and stay safe, and thank you very much.
Thank you, Dr. Jimmy. Before going on to our last panel member, Mr. Guru Prasad, we have few questions which I think have come late, and I would like to place them. One is for Dr. Sandip Pal.
Yes.
Is there any role of antibiotics in HRS-AKI?
Yes, there is a definite role of antibiotic in HRS-AKI, because one of the most common precipitating factors of renal dysfunction is infection. So sometimes clinically it is very difficult to differentiate whether infection is there or not. So while we treat any patient of HRS or creatinine, so it is we usually, when we face the patient, we start on broad spectrum antibiotics, and at the same time also we send the cultures. Like we send a blood culture, we send an ascitic fluid culture, and also the urine culture. So till the report comes, we always start an antibiotic to these patients, because one of the most common cause of precipitation of HRS is infection. So antibiotics is a must.
So thank you. There's another question that is there, do you consider ascitic fluid protein for secondary prophylaxis of SBP?
Yes. So those patients whose ascitic fluid protein is very less, say less than 1 gram, this patient should be on antibiotic prophylaxis, because as if the ascitic fluid protein is less, then this bacterial opsonization and the phagocytosis and all those functions are all altered in the body. So if someone has got a hypoproteinemia or hypoalbuminemia, these patients are more prone to infection. So these are the group of patients whom we start prophylactic antibiotics.
Then there's one more question. Is there any food supplement that can replace albumin, oral albumin powders or some other?
There are a lot of oral albumin powders available in the market, but these tests are not very good. So often I see the patients refuse to take. But yes, these protein powders can be given to these patients. There is some albumin powder also available in the market. Those things can be given. Then anyway, we ask our patient, the best is to have egg protein, animal proteins, egg proteins, or chicken or mutton. All these high protein source we can give. So there is always an idea, because sometimes people will say that you cannot give high protein to these patients, that will precipitate encephalopathy. But yes, it can precipitate encephalopathy, but there is a measurement, 1.2 to 1.5 gram per kg of body weight. So for a 60 kg man, you can easily give 100 grams of protein every day. So 1 egg in the morning, 1 egg in the evening. In addition to that, food, other high protein diet plus albumin powder or protein powder can be given.
And the last question is there any role of intraoperative radiotherapy in liver resection for primary liver cancer?
Dr. Goja will take this.
Yeah. Dr. Goja, if you please unmute yourself.
Yeah.
The role of intraoperative radiotherapy for primary liver cancer.
Are you able to listen to me?
Yes.
Yeah. See, there's nothing like intraoperative radiotherapy. What we can do, intraoperative radio frequency ablation can be done. You see, when you have a doubt of resection margins, or sometimes you have a small nodule less than 3 centimeters, and you think that you cannot resect that along. Suppose it is distant, they are multiple. The remnant liver volume will be less if we take down them. Then you do intraoperative radio frequency ablation, or you inject some sclerosant like ethanol into it. That is what radiotherapy as such, external beam radiotherapy is not given intraoperative.
Thank you, Dr. Goja. So we are almost to the end of our session. It is now my pleasure to invite Mr. M.S. Guru Prasad, who is the group lead of International Division of Narayana Health. Mr. Guru Prasad, please.
Can you hear me, sir?
Yes, we can hear you.
Okay. So thanks for this opportunity, sir. First of all, I mean, I thought let me take this opportunity to just brief about Narayana Health for a couple of minutes, not more than that. So for most of them, they must be knowing that Narayana Health is known for cardiac. So we are into multi-speciality, all the specialties we do. So we have around more than, today as on date, we have more than 6,000 beds, 23 hospitals we have. We have one of the hospital in Cayman Islands, that is in the US region. And recently we have tied up with one more hospital near that Caribbean islands known as St. Lucia. That is one more island. We have just got into that management contract, and we are trying to manage that hospital with, again, that's again a multi-speciality hospital. Those are the two updates. You must be knowing our chairman, Dr. Devi Prasad Shetty. And we have a total employee force of more than 13,000 employee force we have. This is a brief note about us. So we have our contact details, and we thank Dr. Mamun for this great opportunity, first of all, without which this event could not have been so much of successful for us. And thanks Dr. Goja and Dr. Sandeep Pal from our end. This is a brief note, and you can reach us for any kind of medical inquiries. And we are always available for any kind of online consultations. Also, we have recently started for any kind of evaluation, second opinion. We are always reachable. And that's the brief note, sir. Thank you, Dr. Mamun. Thanks, Mom, for this great opportunity.
Thank you very much. Before I conclude, I must once again thank our scientific partner, Beacon Pharmaceuticals, our media partner, Raj TV. Not but least, I must thank Dr. Sanjay Goja and Dr. Sandeep Pal for your time. Thanks to Narayana Health for arranging the show. And of course, thanks to the viewers and the panel of experts for your valuable time. As you know, Forum for the Study of the Liver and BSMMU Hepatology Alumni Association organizes these types of events regularly. We have another one coming up on 16th of this month. We'll notify you in time. Till then, all the best. Thank you.
1 minute, I must at the end thank Dr. Mamoon. I'm highly obliged and thank all the faculty, all the viewers. I think it was a great session, and on the behalf of, I think I will not take time on the behalf of Dr. Sanjeev also, I will say very thankful and thank you very much. Take care, stay safe.
Thank you. Thank you, sir.
Okay.
Good night. Good night.
Good night.
Good night.
Of this session. This session is very niceful, and I also thanks to the both the speaker. They give very much informative for liver transplantation. In our country, we are lag behind the liver transplantation. Most of the patients we treated as conservative. But I hope in near future, with the help of Professor Mamoon Al Mahatab sir, we can be arrange liver transplantation successfully in Bangladesh. A lot of patients where I practice in Naranganj are waiting for liver transplantation. 2 or 3 patients now waiting for liver transplantation to go to India, but in COVID situation they cannot go. I think the situation will improve and they will take the opportunity of nice liver transplantation like robotic surgery. Lastly, I thanks the organizer, the Beacon Pharmaceutical, also Narayana Health, and thank you everybody. Thank you, sir.
Thank you, Dr. Asad. It's now my pleasure to invite Dr. Muhammad Saidul Haq, Assistant Professor of Hepatology at Tajuddin Ahmed Medical College, Gazipur, for his expert opinion, please. Dr. Saidul.
Thank you, sir. I would like to thank you, sir. I am Dr. Mohammad Saidul Haq, Assistant Professor of Hepatology, Shahid Tajuddin Ahmed Medical College, Gazipur. It is my pleasure to attend the session, and I would like to pay my thanks and gratitude to my mentor and honorable teacher, Professor Mamoon Al Mahatab Shapni sir, to arrange such a nice and informative and knowledgeable session. And I would like to give thanks to the honorable speakers, Dr. Dr. Sandip Pal and Sanjoy K. Goza, for delivering their excellent speech regarding chronic liver disease and regarding liver transplantation. Nowadays, we are practicing in different areas of Bangladesh, and we are facing very difficulties in treating decompensated liver cirrhosis patients, and at the end, they need liver transplantation, but there is now in our country, the infrastructure is going on to deliver the liver transplantation in near future. I like and I will hopeful that in near future we will able to do the liver transplantation in our country. So the patients of my country will benefit from this, and they will do the liver transplantation in low cost. And Professor Mamoon Al Mahatab Shapni sir, as mentor and of us and many of his students like me, we hope that he will do the necessary aspects and to arrange liver transplantation in Bangladesh. And again, I like to give thanks and gratitude to all the audience and the organizer of this session. And thanks to all. Thank you.
Thank you, Dr. Saidul Haq. It is now my pleasure to invite Dr. Abul Hayat Mani, hepatologist at Dhaka Medical College, for his expert opinion, please. Dr. Mani.
Thanks, sir. First of all, thanks to Professor Mamoon Al Mahatab sir for giving me the chance to say something here. Then thanks to both the speaker, Dr. Sanjoy K. Goja and Dr. Sandip Pal. I was met with the Sandip Pal in 2018 at your Narayana Health Center during a workshop on endoscopy. Then he conducted a very nice endoscopy workshop that was very helpful to us. And I'd like to say that this lecture was very much helpful for us. That will enrich and liver transplantation lecture by Dr. Sanjoy K. Goja was a nice bit for us. That will help to select a patient with the liver transplantation. First of all, I would like to thanks to the Forum for the Study of the Liver, Hepatology Alumni Association of BSMMO, and Narayana Health Center, and then lastly of all, People Pharmaceuticals for arranging such a program. Thanks to all. Thank you.
Thank you, Dr. Manik. Now, Dr. Debraj Malakar, hepatologist, is working in Manikganj, Munshiganj. So, Dr. Debraj Malakar, if you please give us your expert opinion, please. Debraj, you are not audible.
Dr. Devras, your microphone is not working. Your headphone is not working.
Now can you hear me?
Yes.
Yes, we can hear you.
Thank you. It's a great
Debraj will have released.
So, are you hearing me?
Yes, now
It's a yeah. It's a great.
We cannot hear you, Dr. Devras.
Still, you are not hearing me.
Now I am hearing you.
Come front, Debraj, come front.
Dr. Devras, we are unable to hear you. Hello?
Can you hear?
Yeah.
Yes.
Now we can hear you.
Repeatedly facing the problem, technical problem. Anyway.
Okay, we can hear you now.
Can I start now?
Yes.
Yeah.
It's a great honor for me to be a part of this webinar, where my mentor, my teacher, Professor Mamun Al-Mahatab Shopil sir is present. And he is the iconic figure of medical science in Bangladesh, because he has created much more encourage on the field of hepatology among the students, postgraduate student, graduate, even in undergraduate level. Dr. Sanjay K. Goja, Director and Clinical Lead of Transplant Surgery, Narayana Health, a robotic surgeon, efficient robotic surgeon. Sir has presented his presentation very nicely, and I think all the audience has benefited from his lecture. And Dr. Sandeep Pal, he is actually familiar to me. I had the opportunity to have some conversations over email in 2018 for a training purpose in third space purpose. He also presented his topic nicely. Actually, we're the physician fighting always against the disease to gain our fighting by treating on prevention. And we fight by prevention. That is chronic hepatitis to advanced fibrosis, and prevent advanced fibrosis to cirrhosis, and then cirrhosis to decompensated cirrhosis. Anyway, both of the speakers are excellent. I think all of the audience obviously benefited from this lecture. Thank you, sir.
Thank you. Next, it will be Dr. Abidul Rahman Jimmy. He is resident physician at Shoaib Nazrul Islam Medical College in Kishoreganj. May I ask Jimmy for his opinion, please?
Good evening. Am I audible?
Yes, Jimmy, we can hear you.
Thank you so much. Thanks a lot to our honorable two guest speakers, and thanks a lot to Dr. Sandeep Pal, consultant intervention gastroenterologist and hepatologist, and H. Rabindranath Thakur Intervention Institute of Cardiac Science, Kolkata, for his brilliant and informative lecture on updated management of chronic liver disease and its complications like ascites, renal impairment, inflammatory imbalance, hepatic encephalopathy, peripheral bleeding management, SBP, and Hepatopulmonary syndrome. And also thanks a lot to Dr. Sanjoy K. Guja, Director and Clinical Lead, Senior Consultant, Head of Liver Transplant, Hepatopulmonary and Pancreatic Surgery, Narayana Health, India, for his and informative presentation on liver transplant. And here we can learn how to evaluate a liver transplant patient and indication and contraindication. What is the importance of equity and efficiency in liver transplant and types of liver transplant? What is the prospect of robotic liver transplant? I would also like to express my heartiest gratitude to my mentor, Professor Maunal Mahathir sir, for giving me the opportunity to share my opinion in the and last but not the least, thanks to Beacon Pharma and RAS TV for arranging such a time-demanding webinar on liver transplantation, on chronic liver disease management, and also we are very much benefited from your lectures. And stay safe, and thank you very much.
Thank you, Dr. Jimmy. Before going on to our last panel member, Mr. Guru Prasad, we have few questions which I think have come late, and I would like to place them. One is for Dr. Sandip Pal. Is there any role of antibiotics in HRS-AKI?
Yes, there is a definite role of antibiotic in HRS-AKI because one of the most common precipitating factors of renal dysfunction is infection. So sometimes clinically it is very difficult to differentiate whether infection is there or not. So while we treat any patient of HRS or creatinine, so it is we usually when we face the patient, we start on broad spectrum antibiotics, and at the same time also we send the cultures. Like we send a blood culture, we send an ascitic fluid culture, and also the urine culture. So till the report comes, we always start an antibiotic to these patients because one of the most common cause of precipitation of HRS is infection. So antibiotics is a must.
So thank you. There's another question that is there, do you consider ascitic fluid protein for secondary prophylaxis of SBP?
Yes. So those patients whose ascitic fluid protein is very less, say less than 1 gram, this patient should be on antibiotic prophylaxis, because as if the ascitic fluid protein is less, then this bacterial opsonization and the phagocytosis and all those functions are all altered in the body. So if someone has got a hypoproteinemia or hypoalbuminemia, these patients are more prone to infection. So these are the group of patients whom we start prophylactic antibiotics.
Then there's one more question. Is there any food supplement that can replace albumin, oral albumin powders or some other?
There are a lot of oral albumin powders available in the market, but these tests are not very good. So often I see the patients refuse to take. But yes, these protein powders can be given to these patients. There is some albumin powder also available in the market. Those things can be given. Then anyway, we ask our patient, the best is to have egg protein, animal proteins, egg proteins, or chicken or mutton. All these high protein source we can give. So there is always an idea, because sometimes people will say that you cannot give high protein to these patients, that will precipitate encephalopathy. But yes, it can precipitate encephalopathy, but there is a measurement, 1.2 to 1.5 gram per kg of body weight. So for a 60 kg man, you can easily give 100 grams of protein every day. So 1 egg in the morning, 1 egg in the evening. In addition to that, food, other high protein diet plus albumin powder or protein powder can be given.
And the last question is there any role of intraoperative radiotherapy in liver resection for primary liver cancer?
Dr. Goja will take this.
Yeah. Dr. Goja, if you please unmute yourself.
Yeah.
The role of intraoperative radiotherapy for primary liver cancer.
Are you able to listen to me?
Yes.
Yeah. See, there's nothing like intraoperative radiotherapy. What we can do, intraoperative radio frequency ablation can be done. You see, when you have a doubt of resection margins, or sometimes you have a small nodule less than 3 centimeters, and you think that you cannot resect that along. Suppose it is distant, they are multiple. The remnant liver volume will be less if we take down that. Then you do intraoperative radio frequency ablation, or you inject some sclerosant like ethanol into it. That is what radiotherapy as such, external beam radiotherapy is not given intraoperative.
Thank you, Dr. Goja. So we are almost to the end of our session. It is now my pleasure to invite Mr. M.S. Guru Prasad, who is the Group Lead of International Division of Narayana Health. Mr. Guru Prasad, please.
Can you hear me, sir?
Yes, we can hear you.
Okay. So thanks for this opportunity, sir. First of all, I mean, I thought let me take this opportunity to just brief about Narayana Health for a couple of minutes, not more than that. So for most of them, they must be knowing that Narayana Health is known for cardiac. So we are into multi-speciality, all the specialties we do. So we have around more than, today as on date, we have more than 6,000 beds, 23 hospitals we have. We have one of the hospital in Cayman Islands, that is in the US region. And recently we have tied up with one more hospital near that Caribbean islands known as St. Lucia. That is one more island. We have just got into that management contract, and we are trying to manage that hospital with, again, that's again a multi-speciality hospital. Those are the two updates. You must be knowing our chairman, Dr. Devi Prasad Shetty. And we have a total employee force of more than 13,000 employee force we have. This is a brief note about us. So we have our contact details, and we thank Dr. Mamun for this great opportunity, first of all, without which this event could not have been so much of successful for us. And thanks Dr. Pooja and Dr. Sandeep Pal from our end. This is a brief note, and you can reach us for any kind of medical inquiries. And we are always available for any kind of online consultations also. We have recently started for any kind of evaluation, second opinion. We are always reachable. And that's the brief note, sir. Thank you, Dr. Mamun. Thanks, Mom, for this great opportunity.
Thank you very much. Before I conclude, I must once again thank our scientific partner, Beacon Pharmaceuticals, our media partner, Raj TV. Not but least, I must thank Dr. Sanjay Goja and Dr. Sandeep Pal for your time. Thanks to Narayana Health for arranging the show. And of course, thanks to the viewers and the panel of experts for your valuable time. As you know, Forum for the Study of the Liver and BSMMU Hepatology Alumni Association organizes these types of events regularly. We have another one coming up on 16th of this month. We'll notify you in time. Till then, all the best. Thank you.
1 minute, I must at the end thank Dr. Mamun. I'm highly obliged, and thanks.
You are watching Raj TV Jagoro.
I think it was a great session, and on the behalf
You are watching Raj TV Jagorone Bangladesh. Please subscribe our channel.